Burns. Types of burns. XX thermal injury. Scald, spillage of hot liquids. Flame burns, flash burns due to exposure of natural gas, alcohol, combustible liquids. Contact burns, contact with hot metals, objects, materials. XX electrical injury. XX chemical burns, acid, alkali. XX cold injury, frostbite. XX ionizing radiation. XX sunburns. Classification of burns. Depending on the percentage of burns, burn severity classification: mild, minor, partial thickness burns less than 15% in adult or less than 10% in children. Full thickness burns less than 2%. Can be treated on outpatient basis. Moderate, second degree of 15 to 25% burns, 10 to 20% in children. Third degree between 2 to 10% burns. Burns which are not involving eyes, ears, face, hand, feet, perineum. Major, severe, second degree burns more than 25% in adults, in children more than 20%. All third degree burns of 10% or more. Burns involving eyes, ears, feet, hands, perineum. All inhalation and electrical burns. Burns with fractures or major mechanical trauma. Eye, depending on thickness of skin involved. A. First degree. Here the epidermis looks red and painful, no blisters, heals rapidly in 5 to 7 days by epithelialization without scarring. It shows capillary filling. B. Second degree. The affected area is mottled, red, painful, with blisters, heals by epithelialization in 14 to 21 days. 3/4. Superficial second degree burn heals, causing pigmentation. 3/4. Deep second degree burn heals by causing scarring and pigmentation. Sensation is present but no blanching. C. Third degree. The affected area is charred, parchment-like, painless and insensitive, with thrombosis of superficial vessels. It requires grafting. Charred, denatured, insensitive, contracted full thickness burn is called as eschar. These wounds must heal by reepithelialization from wound edge. D. Fourth degree. Involves the underlying tissues, muscles, bones. 2. Depending on thickness of skin involved. A. Partial thickness burns. It is either first or second degree burn which is red and painful, often with blisters. B. Full thickness burns. It is third degree burns which is charred, insensitive, deep involving all layers of the skin. Rule of 9, Wallace's Rule of 9, 1951. Head and neck. 9%. Front of chest and abdominal wall. 9 times 2 equals 18%. Back of chest and abdominal wall. 9 times 2 equals 18%. Lower limb. 18 times 2 equals 36%. Upper limb. 9 times 2 equals 18%. Perineum. 1%. Degrees of burns. Percentage of burns in A. Adults, B. Children, Wallace's Rule of 9. Assessment of burns. XX Wallace's Rule of 9 is used for early assessment, refer figures 1.219a and b. XX using the London Browder chart is better method for assessing the burns wound. Here each part of the body is individually assessed for involvement of burns. XX patient's entire hand area is 1%. Clean piece of paper is cut to the size of hand and through that percentage of burns is assessed. 44 degrees Celsius temperature takes 6 hours to cause deep burns. 65 degrees Celsius takes 45 to 60 seconds to cause deep full-thickness burn. Burn is a dynamic wound and so assessment should be repeated at regular intervals. First and second degree burn. Second degree burns with blisters. Extensive third degree burns with eschar. Extensive burns more than 50%. Third degree burns with charred skin, with thrombosed veins and eschar. Face burns in an adult, severe third degree. Clinical features: history of burn, pain, burning, anxious status, tachycardia, tachypnea, fluid loss. In severe degrees, features of shock. Tolerable temperature to human skin is 40 degrees Celsius for brief period. Pathophysiology: heat causes coagulation, necrosis of skin and subcutaneous tissue. Down pointing arrow. Release of vasoactive peptides. Down pointing arrow. Altered capillary permeability. Down pointing arrow. Loss of fluid. Right pointing arrow. Severe hypovolemia. Decreased cardiac output. Decreased myocardial function. Decreased renal blood. Right pointing arrow. Oliguria flow, renal failure. Altered pulmonary resistance causing pulmonary edema. Down pointing arrow. Infection. Down pointing arrow. Systemic inflammatory response syndrome, SIRS. Down pointing arrow. Multi-organ dysfunction syndrome, MODS. Fig. 1.220. Third degree burns with. There is increased capillary permeability, decreased plasma oncotic pressure causing loss of protein and fluid from intravascular space. Vasoconstriction occurs due to raised capillary hydrostatic pressure leading into cellular aggregation. Blockage of lymphatics causes poor clearance of fluid and proteins from interstitial spaces. Cell membrane function is impaired causing intracellular fluid accumulation. Activation and release of various complement factors, histamine, and prostaglandins results in myocardial dysfunction, edema of tissues, reduced immunoglobulin synthesis. Catecholamine levels are raised drastically in patient with burn. There will be lipolysis, proteolysis, increased release of glutamine and alanine from skeletal muscles. Urea production is increased due to more proteolysis. Burn zones, Jackson's. Massive edema in the body is due to altered pressure gradient because of the injury to basement membrane. Cardiac dysfunction is due to hypovolemia. Release of cardiac depressants. Hormonal causes like catecholamines, vasopressin, angiotensins. Renal changes are due to release of UD from posterior pituitary to cause maximum water reabsorption. Release of aldosterone from adrenals to cause maximum sodium reabsorption. Toxins released from the wound along with sepsis causes acute tubular necrosis. Decreased myocardial output function. Down pointing arrow. Decreased renal blood. Right pointing arrow. Oliguria flow, renal failure. Myoglobin released from muscles, in case of electric injury or often from eschar, is most injurious to kidneys. Pulmonary changes are due to altered ventilation-perfusion ratio. Pulmonary edema due to burn injury, fluid overload, inhalation injury. ARDS, aspiration, septicemia. Assessment of airway injury is important in burns. XX occurs in burns around face and neck, or trapped in burning room. XX presents with hoarseness or stridor. XX inhaled burning gases can cause upper airway burns and laryngeal edema. XX smoke inhalation can cause chemical alveolitis, pulmonary edema, ARDS and respiratory failure. XX steam inhalation can cause damage to respiratory epithelium and subglottic edema. XX carbon monoxide inhalation more than 10% is dangerous as it forms carboxyhemoglobin. Colorado has got 240 times more affinity to hemoglobin than oxygen, which blocks oxygen transport completely, causing respiratory arrest, hypoxia and metabolic acidosis. XX chest wall burn causes mechanical block of ventilation, needs escharotomy in chest wall and the procedure is painless. XX airway burn may require early elective intubation or tracheostomy, or emergency cricothyroidotomy is a life-saving method. GIT changes are due to acute gastroregulation which occurs in 2 to 4 days. Paralytic ileus, Curling's ulcer, due to decreased mucosal defense, not due to increased HCl. Cholestasis and hepatic damage. Acute acalculous cholecystitis, acute pancreatitis can occur. Bowel mucosal ischemia causes poor motility, reduced food digestion and absorption with increased translocation of bacteria causing peritoneal edema, septicemia and abdominal compartment syndrome. Metabolic changes. Hypermetabolic rate, BMR. Negative nitrogen balance, electrolyte imbalance. Deficiencies of vitamins and essential elements. Metabolic acidosis due to hypoxia and lactic acid. Sepsis in burn patient. Focus may be at the burn site, catheter site, cannula, CVP line site, or respiratory infection. Low immunity, loss of proteins and immunoglobulins, loss of barrier causes sepsis. Opportunistic infection is also common. Associated conditions like diabetes, HIV infection, old age, respiratory diseases worsen the sepsis in burn injury. It may be local infection commonly by Staphylococcus aureus in early period, Pseudomonas, Candida, Aspergillus, herpes simplex virus in partial thickness nasolabial burns. It may be suppurative thrombophlebitis also. Systemic infection like pneumonia, bacteremia, septicemia can occur. Burns itself creates immunosuppression, cell-mediated immunity. Sepsis is identified by fever, lethargy, leukocytosis, thrombocytopenia. Infections are commonly due to 125. XX streptococci, beta hemolytic, most common, XX pseudomonas, XX staphylococci, XX other gram-negative organisms, XX candida albicans. Burns over chest wall with eschar. Note the extent of involvement. Effects of burn injury. Shock due to hypovolemia. 15% of burns causes shock. Renal failure, pulmonary edema, respiratory infection, adult respiratory distress syndrome, ARDS, respiratory failure. Infection by Staphylococcus aureus, beta hemolytic streptococcus, Pseudomonas, Klebsiella leads to bacteremia, septicemia. Fungal and viral infections of dangerous types can also occur. GIT, hypovolemia, ischemia of mucosa, erosive gastritis, Curling's ulcer, seen in burns greater than 35%. Fluid and electrolyte imbalance. Post-burn immunosuppression predisposes to severe opportunistic infection. Eschar formation and its problems like defective circulation, ischemia when it is circumferential. Electrical injuries often cause fractures, major internal organ injury, convulsions. Development of contracture is a late problem. It leads to ectropion, microstomia, disability of different joints, defective hand functions, growth retardation causing shortening. Inhalation burn causes pulmonary edema, respiratory arrest, ARDS. Chemical injury causes severe GIT disturbances like erosions, perforation, stricture esophagus, alkali, pyloric stenosis, acid, mediastinal injury. Other problems commonly seen are DVT, pulmonary embolism, urinary infection, bed sores, severe malnutrition with catabolic status, respiratory infection. Deep burns face with eyelid involvement. Burns hand both palmar and dorsal aspect. Deep burn in the scalp involving extensively. Complications of burns: contracture itself like hypertrophic scar, keloid formation. Toxic shock syndrome. It is a life-threatening exotoxin-mediated disease caused by Staphylococcus aureus. It is common in children, presents with rashes, myalgia, diarrhea, vomiting, and multi-organ failure with high mortality. B. Causes of death in burns. XX hypovolemia, refractory and uncontrolled, and shock. XX renal failure, XX pulmonary edema and ARDS, XX septicemia, XX multi-organ failure, XX acute airway block in head and neck burns. Management of burns: first aid. Stop the burning process and shift the patient away from the burning area. Cool the area with tap water by continuous irrigation for 20 minutes, not cold water as it can cause hypothermia. B. Indications for admission in burns: A. XX any moderate and severe burns, XX airway burns of any type, XX burns in extremes of age, XX all electrical, deep chemical burns. Initial management: B. Fix 1.225 A and B. Burns. XX clothing should be removed. XX cooling of the part by running water for 20 minutes. XX cleaning the part to remove dust, mud, etc. XX chemoprophylaxis, tetanus toxoid, anti-tetanus globulin, ATG, 500 units, IM, antibiotics, local antiseptics. XX covering with dressings by different methods. XX comforting with sedation and painkiller. Definitive treatment. Admit the patient. Maintain airway, breathing, circulation, ABC. Emergency endotracheal intubation may be required in early period itself. In such situation, succinylcholine should not be used. Fig. 1.226. Deep burn. Assess the percentage, degree, and type of burn. Keep the patient in a clean environment. Sedation and proper analgesia. Patient should be placed in burns unit, ideally air-conditioned, with barrier nursing, sterile clothes, bed sheets with all aseptic methods. Extensive burn patient of fluid therapy with CVP line. Fluid resuscitation. Formulas to calculate the fluid replacement. Parkland regime, commonly used, 4 ml per percent burn per kilogram body weight, 24 hours. Maximum percentage considered is 50%. Half the volume is given in first 8 hours, rest given in 16 hours. Mio and Beckley regime, for colloid after 12 to 24 hours. Percent burns times body weight in kilogram. 2. 1 ration. Three rations given in first 12 hours. 2 rations in second 12 hours. 1 ration in third 12 hours. B. Other regimes. XX Galveston regime, pediatric, 5000 ml per square meter burn plus 1500 ml per square meter total. XX modified Brook formula, first 24 hours, RL, 4 ml per kilogram per percent burns in 24 hours, first half in first 8 hours, colloid, none. Second 24 hours, crystalloids, to maintain urine output, colloids, 0.3 ml to 0.5 ml per kilogram, burns in 24 hours, albumin in RL solution, albumin alone should be given with care if really indicated only. XX Evans formula, in first 24 hours, normal saline 1 ml per kilogram per percent burns, colloids 1 ml, kilogram per percent burns, 5% dextrose in water, 2000 ml in adult. In second 24 hours, half of the volume used in first 24 hours. Fluids used are Ringer lactate, Hartmann fluid, plasma. Ringer lactate is the fluid of choice. Blood is transfused in later period, after 48 hours. First 24 hours only crystalloids should be given. Crystalloids are one which can pass through capillary wall like saline, either hypo, iso or hypotonic, dextrose saline, Ringer lactate. Sodium is assessed by formula 0.52 millimoles times kilogram body weight times percent body burns, given at a rate of 4.0 to 4.4 milliliters per kilogram per hour. After 24 hours up to 30 to 48 hours, colloids should be given to compensate plasma loss. Colloids are one which are retained in intravascular compartment. Plasma, hemixel, gelatin, dextrans, hetastarch are used. Usually at a rate of 0.35 minus 0.5 milliliters per kilogram per percent burns is used in 24 hours. Human albumin is ideal colloid. Urinary catheterization to monitor output, 30 to 50 milliliter per hour should be the urine output. Tetanus toxoid, monitoring the patient, hourly pulse, BP, PO2, PCO2, electrolyte analysis, blood urea, nasal oxygen, often intubation is required. IV ranitidine 50 mg 8th hourly. Riley's tube insertion initially for aspiration purpose, later for feeding, enteral feeding. For burns greater than 15%. Antibiotics, penicillins, aminoglycosides, cephalosporins, metronidazole. Culture of the discharge. Total white cell count and platelet count at regular intervals are essential to identify the sepsis along with fever, tachycardia and tachypnea. In burns of oral cavity, tracheostomy may be required to maintain the airway. Total parenteral nutrition, TPN, is required for faster recovery, using carbohydrates, lipids, vitamins, through a CVP line. Tracheostomy, intubation tube may be required in impending respiratory failure or upper airway block. Intensive nursing care. Local management. Dressing at regular intervals under general anesthesia using paraffin gauze, hydrocolloids, plastic films, Vaseline impregnated gauze or fenestrated silicone sheet or biological dressings like amniotic membrane or synthetic biobrain. Open method with application of silver sulfadiazine without any dressings, used commonly in burns of face, head and neck. Closed method is with dressings done to soothe and to protect the wound, to reduce the pain, as an absorbent. Tangential excision of burn wound with skin grafting can be done within 48 hours in patients with less than 25% burns. It is usually done in deep dermal burn wherein dead dermis is removed layer by layer until fresh bleeding occurs. Later skin grafting is done. Advantages of tangential excision: it reduces the chance of secondary infection, the hospital stay, and formation of hypertrophic scar or contracture. The cost. In burns of head and neck region, exposure treatment is advised. Slough excision is done regularly. After cleaning with povidone iodine solution, silver sulfadiazine ointment is used. It is an antiseptic and soothing agent. It causes neutropenia. Topical agent. Advantages. Problems. Silver sulfadiazine, 1%. Antiseptic, G plus V and G-way. Soothing, good penetration, hydration and softening of eschar occurs. It does not cause pain. Neutropenia, pseudoshar, it diffuses poorly through the eschar. Causes hypertrophic granulation and so not used once wound is clean and eschar is separated. Causes wound maceration, it should be avoided in pregnancy, nursing mother and infants below 2 years of age. Sulfamylin, 5%, 11%. Antipseudomonal, anticlostridial. Very irritant, painful. Mafenide acetate. Penetrates very well into tissues, it is water-soluble, it is good anti-pseudomonal agent. Causes acidosis, by inhibiting the carbonic anhydrase. Silver nitrate, 0.5%. Antiseptic, anti-pseudomonal. Stains burnt area. Povidone iodine, 5%. Antiseptic, G+V, G-way. Used on granulation tissue after eschar separation. Used in perineum and buttocks to prevent maceration. Irritant and painful, not used in partial burns. Silver sulfadiazine and cerium nitrate. Boost cell-mediated immunity and forms sterile eschar. Other agents used are sulfamelin, mafenide acetate, and silver nitrate. 3/4. Sulfamelin is anti-pseudomonal and anticlostridial agent. It penetrates well into the tissues but it is very irritant. It causes acidosis. 3/4. Silver nitrate causes staining of burnt area. 0.025% sodium hypochlorite, Dakin solution, is effective against gram-plus-V organisms. 0.25% acetic acid is effective against gram-V organisms, but both mildly inhibit epithelialization. Regular culture and sensitivity for bacteria is required, to see. 3/4. For streptococcal growth which should be less than 100,000, 105 per gram of tissues. Wound coverage. Once the area granulates well, in 3 weeks usually, split skin grafting is done, SSG, Thiesch graft. For wider area mesh split skin graft is used. If there is eschar, escharotomy is required to prevent compression of vessels. In certain areas like face and ear, full thickness graft, wolf graft, or flap is required. Cultured skin. Full thickness skin biopsy of patient's skin is done immediately after admission. By specialized culture technology, sheets of skin can be manufactured in 3 weeks as cultured epithelial grafts. It can cover skin of almost entire body. It is usually useful in burns of greater than 80%. Take-up of cultured graft is 60 to 75%. Limitations are, time taken to develop cultured graft, more vulnerability for mechanical trauma, costly, time taken to manufacture, scarring. Synthetic dressings in burn wound. Vaseline impregnated gauze dressing prevents stiffness of eschar. Hydrocolloid dressing, Duoderm, helps moist environment, proper epithelialization. It is useful in mixed deep burns. It is changed once in 3 days. Opsite is less expensive, with less pain, creates moist barrier. But it does not have antimicrobial effect and it causes accumulation of exudates. BioBrain is collagen-coated silicone sheet which gets adherent to wound acting as barrier without any pain. But it does not have antimicrobial effect and it causes accumulation of exudates. It is used for second-degree burns. Transite has similar features of BioBrain. It contains growth factor derived from cultured fibroblasts which promotes wound healing. Integra contains deeper collagen matrix as dermal substitute. Outer silicone sheet is epidermal substitute. Inner collagen matrix acts as dermis whereas outer silicone sheet is removed 2 weeks after dressing and additional autograft should be placed. It provides complete wound cover. Scarring after healing is reduced significantly. Biologic dressings for burn wound. It is used to cover the wound temporarily as a barrier and also to have some immunologic function. Eventually graft will slough. Later wound is covered with autoskin graft. It is used for massive burn injuries more than 50%. Possible problem is transmission of viral diseases. Xenograft is of pig skin. Allograft is of cadaver skin. Homograft, it gives all existing normal skin function for temporary period. It may leave a dermal equivalent in the wound later. ESCHAR. It is charred, denatured, full thickness, deep burns with contracted dermis. It is insensitive, with thrombosed superficial veins. Circumferential eschar in the upper limb, lower limb, neck, thorax can cause more edema, which initially causes venous compression and later arterial compression, causing ischemia, gangrene of the distal part. So distal area should be monitored for circulation. If required, deep longitudinal full thickness incisions are made in different areas so as to prevent collection of edema fluid and also to prevent compression over the vessels. This is called as escharotomy. Escharotomy causes large quantity of blood loss and so blood transfusion is needed while doing escharotomy. Incision should be of adequate length and depth during escharotomy. It should be placed in such a way so as to avoid injury to major neurovascular system. Release of muscle compartment is needed often in these patients. Extensive eschar involving both thighs. Multiple incisions or incisions over the joints may be needed. Early rapid separation of eschar indicates severe sepsis underneath. Eventually eschar should be excised and the area is allowed to granulate and skin grafting should be done. Pseudosure is thickened burn skin due to repeated silver sulfadiazine application. Contracture in burn wound. Contracture in burns can occur anywhere. It is more common where inflexibility and mobility is present, like along the joint, eyelids, cheeks, lips, neck, elbow, knee, etc. Contracture can be intrinsic by loss of tissue or extrinsic by pull during healing phase contraction. Contracture proceeds towards position of comfort until it meets or closely reaches opposite surface. There is clearly wound shortening. Disorganized overformation of compact collagen, 3 times normal, causes hypertrophic scar leading further contracture. Deficit of neck extension is graded, normal greater than 110 degrees, E1 95 to 110 degree, E2 is 85 to 95 degree, E3 is less than 85 degrees with mentosternal synechia. Classification of burns contracture in the neck, B. mature. XX mild, less than 1/3 road, inability to see ceiling. XX moderate, 1/3 road to 2/3 road, flexion is possible but not extension. XX severe, more than 2/3 road, fully contracted in flexed position with pull on lower lip. XX extensive, contraction is extensive with mentosternal adhesions. Ifinichikwu has classified neck contracture into Type 1, mild anterior with narrow contracting band less than finger breadth, 1A, or broad band, 1B, Type 2, moderate anterior with narrow band, 2A, or broad band, 2B, Type 3, severe anterior mentosternal adhesion with supple neck skin, 3A, or without supple skin, 3B, Type 4, posterior with narrow band, 4A, or multiple or broad band, 4B. Reconstruction territories in neck in burn contracture based on functional benefits are central above, central below, central above and below, lateral. Complications of burns contracture: ectropion of eyelid causing keratitis and corneal ulcer, disfigurement in face, narrowing of mouth microstomia, contracture in the neck causing restricted neck movements, disability and non-functioning of joints due to contracture, hypertrophic scar and keloid formation, repeated breaking of scar and infection, ulcer, cellulitis, pain and tenderness in the scar contracture, Magellan's ulcer. Refer Chapter 1b. Treatment for contracture Fig. 1.228, extensive eschar involving both thighs. Release of contracture surgically in use of skin graft or Z, plasty or different flaps. Different flaps used are transposition flaps, vertical or transverse, laterally based flap, bilobed flap, bipedical flap, advancement flap, regional flap, random cutaneous flap, epaulette flap, choroidal flap, fasciocutaneous, myocutaneous flap, tube flap, expanded skin flap, combined skin graft and flap, microvascular free flap. Proper physiotherapy and rehabilitation is essential. Pressure garments to prevent hypertrophic scars. Management of itching in the scar using aloe vera, antihistamines and moisturizing creams. Problems in managing burn contracture. Giving proper anesthesia is challenging. Scar excision can cause significant bleeding. Ectropion of upper eyelid due to burns. Contracture at different parts of the body, chest, face and neck. Magellan's ulcer developed over burn scar. B. Severe contracture at knee joint causing deformity. C. Same patient with knee contracture undergoing release surgery. Infant had burns in head and neck region causing severe contracture. B. Elbow contracture due to burns. C. Keloid in the hand after burn injury. Identifying major structures in the area and safeguarding vascular and other structures is often worrisome. Need for repeated surgeries is staged 1. Maintaining the position with skeletal traction, fixation, collar, pop cast, etc. Psychological problems and needs counseling. Prolonged hospital stay, cost factors. Prevention of development of contracture. XX joint exercise in full range during recovery period of burns. XX pressure garments for a long period. XX topical silicone sheeting, saline expanders for scars. High voltage electric burn wound of entry in the hand with extensive destruction. Some patient showing wound of exit in the buttock which is extensive and deep. Wound of entry in an electric burn. Electrical burns. Types of electrical injury. 131. Low tension injury, less than 1000 volts. High tension injury, more than 1000 volts, may be due to current itself causing intense damage on the tissues up to 2000 degrees Celsius. Flash injury due to electrical arc up to 4000 degrees Celsius. Flame injury by catching of fire to the clothing and body. Traumatic injury like fractures and internal organ injuries. A. It is always a deep burn, always a major burn. There is a wound of entry and wound of exit. Patient may also have major internal organ injuries. GIT, thoracic injuries. Often convulsions can develop. Death may occur due to cardiac arrhythmias, instant death due to ventricular fibrillation. Gas gangrene is common after electric injury. Release of myoglobin can cause renal tubular damage and renal failure. Acidosis is common and so often bicarbonate infusion is needed. Patient should always be admitted and should be assessed by ECG, cardiac monitor, ultrasound, US, abdomen, chest X-ray, sometimes even CT scan head, cardiac enzyme analysis. Depending on the injury, it is managed accordingly. Fractures and dislocations are common in electrical injuries, which is treated accordingly. Mafenide acetate is better agent as it penetrates well and it is useful against clostridial infection. Mannitol is used to prevent myoglobin-induced renal failure. Wound excision, amputation, surgery for internal organ injury, cardiac monitoring are essential part of the surgical management. Inhalation injury Fig. 1.234, wound of entry. It occurs after major fire burns in vehicle, airplane, train accidents. Electrical burns. Types. High voltage can cause ventricular fibrillation, cardiac arrest, death. Extensive organ and surface injuries with fractures. Low voltage, deep burn at the site of wound of entry. Treatment. Emergency resuscitation assessment of burn. Prevention of renal failure by hydration, dialysis, alkalization of urine to clear myoglobin, mannitol therapy, IV sodium bicarbonate. Extensive fasciotomy, debridement, infection control, reconstruction. Complications. Neurological like epilepsy, hemiplegia, aphasia, memory loss, headache, transverse myelitis. Cardiac, arrhythmias, vascular injuries, major vessels, bleeding. Compartment syndromes, ischemia, gangrene of limbs. Contracture development, bronchopneumonia, pleural effusion. Abdominal, ileus, erosive gastritis, curling. Ulcer, injury to liver, pancreas, spleen, GIT, ARF. Bone and joint injuries. Cataract can occur in high voltage burn. Severe potassium deficiency is common. Monitoring and prevention. Monitoring, ECG, echocardiography, relevant investigations like X-ray, ultrasound, CT, electrolytes, urine analysis, LFT, renal function tests. Prevention, care during electrical work and with electrical system. Unused outlets should be sealed with plastic. Electrical system should be away from water source. It is due to 3/4 inhalation of heat, noxious gases and incomplete products of combustion. At the site of fire, oxygen concentration is less than 2%, which can cause death in 45 seconds due to hypoxia. Inhaled carbon monoxide binds with Hb immediately to form carboxyhemoglobin, causing severe anoxia and death. Carbon monoxide, CO, has got 240 times more affinity for hemoglobin than oxygen. Carboxyhemoglobin in blood more than 10% is dangerous, more than 60% is life-threatening. Symptoms of carbon monoxide intoxication: headache, disorientation, visual changes, fatigue, vomiting, hallucinations, shock and cardiac arrest. Smoke contains hydrocyanide, which causes tissue hypoxia and profound acidosis. Laryngeal edema and laryngospasm. Bronchial edema and bronchospasm. Formation of bronchial cast is typical, which is due to edema, lymph exudation, separation of ciliated epithelial cells from basement membrane. Inhaled gas causes supraglottic airway burn, laryngeal edema, loss of respiratory epithelium, acute respiratory distress syndrome, ARDS, Colorado poisoning, mechanical restriction of chest wall movement. Later problems: ARDS, pneumonia, atelectasis, pulmonary embolism, pulmonary edema, pneumothorax. Features: they have low oxygen saturation. charring of mouth, oropharynx with facial burns. Carbon sputum. Change in the voice, singed facial and nasal hair. Decreased level of consciousness with stridor or dyspnea. Acute pulmonary insufficiency with asphyxia, Colorado poisoning, upper airway obstruction. After 3 to 5 days, ARDS and hypoxia develops. Bronchopneumonia with septicemia occurs after 5 days. Management. Replacing the patient from the site earliest. Ventilator support for several weeks. Antibiotics. Bronchoscopy, at regular intervals to remove bronchial cast. Tracheostomy whenever required. Hyperbaric oxygen. IV heparin to reduce bronchial cast. Heparin nebulization, 10,000 units in 3 ml saline 4th hourly, is also useful. N-acetylcysteine nebulization, 20% in 3 ml saline 4th hourly, bronchodilators like albuterol 2nd hourly is very useful. Hypertonic saline inhalation induces the effective coughing to remove casts. Racemic epinephrine is used to reduce mucosal edema. Monitoring the patient with arterial blood gas analysis regularly. Note: steroids are not beneficial in inhalation burns. In chemical burns, tissue destruction is more progressive. It is always a deep burn. Acid burn occurs in skin, soft tissues and gastrointestinal tract (GIT). In GIT, it is common in stomach either due to nitric acid or sulfuric acid, which may lead to severe gastritis or pyloric stenosis. Other acids are formic acid, hydrofluoric acid. They cause metabolic acidosis, renal failure, ARDS, hemolysis. Acidemia should be corrected by IV sodium bicarbonate. Hydrofluoric acid is commonly used in industrial areas. It is strongest inorganic acid that can produce corrosion and dehydration. It chelates blood calcium, causing hypocalcemia and arrhythmias. It is managed with water irrigation, application of 2.5% calcium gluconate gel at 15 minutes interval, local intradermal and intra-arterial injection of 10% calcium gluconate. Continuous cardiac monitoring, IV calcium gluconate or calcium chloride administration is needed. Alkali burns occur in oral cavity and esophagus, which leads to multiple esophageal strictures. Sodium hydroxide, lime, potassium hydroxide and bleach are common alkalis involved. They cause saponification of fat, fluid loss, release of alkali proteinates and hydroxide ions, which are toxic. External chemical burns are always deep and cause extensive disfigurement with cosmetic problems. Initial treatment is dilution with water, hydrotherapy. It is done using 15 to 20 liters of running tap water. Neutralization with antidote should never be done at initial phase of treatment, as it creates exothermic reaction which aggravates the tissue damage. Late neutralization is done, if required, by 0.2% acetic acid in alkali burns, sodium bicarbonate, calcium gluconate 10% gel, topical zephrine solution in acid burns. Treatment should always be with hospitalization. Mannitol diuresis, hemodialysis, calcium gluconate IV, pain relief, serum electrolyte management, total parenteral nutrition, TPN, ventilator support are systemic management required. Late treatment is reconstruction of the face. Esophageal dilatation or colonic transposition is done for esophageal stricture due to alkali burn. Gastrojejunostomy is done for acid-induced pyloric stenosis. Tar burns are treated additionally with neosporin, which contains tween 80 emulsifier of tar. Cement is calcium oxide alkali. Its burn is due to hydroxyl ion, which is often deep. Treatment is removal of cloth, irrigation with water, keeping pH below 8. Often it may form eschar. B. Medicolegal and ethical aspects in burns. XX police should be informed whenever a female, pregnant patient arrives with burns. XX consent for high risk should be taken, especially in burns greater than 30%. XX burns should be assessed whether it is accidental or homicidal. XX relatives should be informed about the duration of stay, problems, repeated surgeries. XX in patients with severe burns who is likely to die. When suspected, dying declaration should be arranged. XX cost of therapy, long duration of stay and cosmetic problems should be informed to the relatives.